Hi, good morning, everybody. For those of you that don't know me, my name's Carrie George, and I'm the Division Chief in Pediatric Critical Care Medicine, and I'm really excited today to introduce Dr. Jennifer Needle. She joined our division in 2013. Her training took her all over the country. She started out at WashU for her bachelor's. Her MD was at Howard University. She did residency and fellowship in Cleveland at Rainbow Babies. But then along the way, she obtained additional training if that wasn't enough. Her MPH in epidemiology was at Emory University. And then she also did a fellowship in medical bioethics at Oregon Health and Science University. So she's come to the University of Minnesota. We're very grateful, thankful, and she's been able to start just a wonderful career in combining all of this training in epidemiology, bioethics, and critical care medicine. And I'll let her share with you how she has done that.
Thank you, Carrie. Just the formalities, I have no conflicts to disclose. And I imagine you're wondering why a pediatric intensivist is up here talking about advanced care planning. Not the typical discussion we have during grand rounds when we're talking about intensive care. But I think that we have access to amazing medical technology these days, especially in the ICU. And we spend quite a bit of time thinking about whether or not that technology will be effective and helpful for the patients we treat. And I think we also have responsibility to be ethical stewards of that technology and to make sure that when we use that technology and aggressive treatment, that's treatment that's desired by the patient. And I think we don't always spend as much time as we should making sure that that treatment is consistent with what the patients want. And when we ask families and patients to make decisions about whether or not they want aggressive, life-sustaining treatment in the midst of a crisis, it's not always obvious that they're making that decision based on really thoughtful experience, more that in the moment, let's try. And so I have become interested in the concept of advanced care planning for patients that may end up in the ICU, to give them the opportunity to be thoughtful about the decisions they might have to make in the future, so that both they get the desired treatment that they want and their families know when they make decisions that they're making them consistently with what their child would want. I'm going to start off this morning with a little food for thought with my Yoda, Atul Gawande, or not.
So is curing disease an important job of a doctor? It's an important job, but ultimately it's also coping with the fact that not all problems are curable, not all problems are fixable. And then that means understanding what people are willing to trade off for the sake of trying to manage an unfixable problem. You know, you can talk about problems like diabetes, blood pressure, you can talk about aging, you can talk about the end of life. And in all instances, we're asking people to sacrifice some of their time now for the sake of time later. But there are outcomes that are unacceptable to people, trade-offs they're not willing to make, and trade-offs they're willing to make. And if we don't understand that, that's when we cause suffering, that's when we fail people tremendously. So cure is almost always the first goal when it's possible. But in the course of human life, it simply isn't always. Aging and dying are certainly unavoidable parts of the human existence. So we have to be good at more than just cure if we're going to be great at what we do.
So I'm going to spend the next 40 to 45 minutes or so, because I want to leave time for some discussion at the end, to talk a little bit about this newly evolving concept of advanced care planning for adolescents and young adults, specifically those under the legal age of majority of 18. I want to spend a bit of time exploring the very limited literature we have on this topic to address a couple of the misconceptions and myths that I have heard people bring up when we talk about doing advanced care planning for children and adolescents. And then I'd like to share with you my preliminary data from a study we are currently in the process of doing in bone marrow transplant patients. So no lecture by an ethicist would be complete without discussing Nancy Cruzan, and I'm sure most of you have heard of her, but if not, she really was an unfortunate young woman who is essentially an originator of the right to die movement and the development of the concept of patients' rights to make end-of-life choices. She was 25 years old when she was in a terrible car accident that left her severely brain injured, and in the acute course of her treatment received a G-tube for nutrition, and then ultimately was diagnosed as being in a permanent vegetative state. And at that point, her family made the choice after the awareness came out from her roommates and some of her coworkers that she had spoken about how she would never want to live that way. And they wanted to withhold fluid and nutrition. And her parents requested that of the hospital, and they were not allowed to do so. The state of Missouri fought the family to not allow the family to withhold fluid and nutrition from her. It ultimately went through multiple state courts, and it wasn't until 9 years later of her living in a permanent vegetative state that the courts allowed the parents to make the decision to withhold fluid and nutrition. I think her headstone is very symbolic that she departed in 1983 and actually died in 1990. But a year after Nancy Cruzan's death, the federal government passed the Patient Self-Determination Act, which required all hospitals receiving Medicaid and Medicare to approach patients about advanced care planning and advanced directives, to give them the opportunity to both name a proxy and to note any preferences they had for whether or not they would want to receive aggressive end-of-life treatment. So where have we come since 1990 to 2012? Well, a study recently in California of just the general public asked people whether or not they thought talking to their loved ones about end-of-life care was important. And as expected, I think we would all say, yes, that's important, 90% of us. 87% have actually done it. And they asked them if they were seriously ill, if they would want to talk to their doctor about those specific treatments that they may or may not want at the end of life. Of course, a vast majority said they would want to, and very few of them had actually done it. So despite the fact that the concept of advanced care planning and advanced directive completion is out there in the universe, there is still stigma attached to the concept and difficulty, and I am going to hopefully today put more of the onus on us to do a better job and not expect the patients to be the initiators of the conversation. So why does it matter to us if patients don't complete advanced directives or don't have an end-of-life care plan? And before I go into this, I want to emphasize that the principle of advanced care planning is to help patients elicit their goals and values, not to get patients to make the choice to not get aggressive care. It is not to get the DNR. It is to make sure that a conversation takes place so that there's an understanding of patient preferences and that that's communicated to their family members and physicians so that if there's a time when someone has to make a decision for them, that conversation has already taken place. But what we know, and the majority of the literature in this is in cancer, so most of the studies I'll present to you are talking about patients with cancer, with a few exceptions. But we know from both adult and pediatric literature, the top study is in adolescents and young adults. The bottom study is in adults between 30 and 65, that somewhere between 60 and 75% of patients with cancer receive what would be considered intensive end-of-life care in their last 30 days of life. I don't show this slide to say that we're doing something wrong. I'm showing this slide to say that I want to make sure that those patients that receive intensive end-of-life care in their last days are getting the care that they would have wanted. And so having the conversation to make sure that they would want to get chemo, that they would want to be admitted to the ICU, is really where we need to move to. So what is advanced care planning? It varies based on the particular program that a hospital has. But in general, the principle of it is that there is some interventionist facilitator helping a patient have a conversation with their surrogate decision maker to discuss their goals and values, any concerns they have about their illness, what the experience of their illness has been and what they anticipate it might be in the future, to talk to them about what matters to them. What my child is getting married 2 years from now, I have to be alive to be there. Okay, let's figure out what that plan is to get you to 2 years from now. To make sure that there aren't unanswered questions that patients have that might impact the way they make decisions, and then to come together between the surrogate, the patient, and the provider and develop a plan. And that plan could be a formal advance directive document or not.
My wishes.
So I want to talk about how advanced care planning can benefit adolescents and young adults. And it follows the same logic in younger patients as it does in adults, with a couple extra benefits, I think. We all know that adolescents are at a time of evolving autonomy. They want to be more responsible for making decisions, but may not always really understand how to make the best decision. But not including them in that decision is not acceptable to them given their near adulthood. So by including adolescents with life-limiting illness in advanced care planning, we give them a voice, make them feel less helpless. Without a doubt, it helps parents who recognize that they should talk to their children about this, that they need to have that conversation, but are afraid of how to do it, are unfamiliar with the language that should be used, that they are too uncomfortable about how to bring it up and when. And I think it also has an added benefit for providers. As I talked about before, being ethical stewards of our technology, I think knowing when you put a patient on ECMO that they understood the decision that they were making is an extra support to you in a conflicted decision-making schema. So what are some of the misconceptions or misunderstandings about embarking on adolescent advanced care planning? And I put these in order of what I think people feel, but I may be wrong and you can tell me. We'll discuss it at the end. I think first and foremost, pediatricians, it is our knee-jerk reflex to refer to the parent. The parent makes the decision. Sometimes we actually only talk to the parent about the decision, even if the patient is 16 or 17. And that has to do with the fact that the age of majority in this country is 18. And so, in fact, you aren't necessarily able to execute any decision under the age of 18 without the consent of your parents. So there is truth to the fact that adolescents do not have legal rights to make end-of-life decisions, but I'm going to address that a little bit further. And then if there's one thing I hope to talk about and dispel throughout the course of this talk is that talking about potential bad outcomes in treatment or talking about advanced care planning topics takes away patients' hope and takes away their hope for cure. The data 100% do not support that to be true. And so the idea that we can't talk about it because we don't want them to lose hope is a fallacy, and I hope that we can talk about that a little bit further. The idea that patients and families don't want to talk about it. In our research, we have absolutely found that to not be the case. Of course, there are exceptions to the rule, just like there are exceptions to the rule in adults. But in tremendous feedback about how beneficial the program was for them. And then last but not least, a topic in and of itself that we could spend hours talking about is, the development of decision-making capacity in adolescence and how that spectrum occurs and when it occurs and when adolescents can be considered to be making good decisions. I will tiptoe into that, but I think that's a topic that needs a lot of time. So what about this idea that adolescents do not have the legal right to decide? So as pediatricians, we are very accustomed to deferring to parental preferences for most decisions. And as children get older and develop into adolescence, sometimes we forget that they may be in a different position and want to participate in that decision-making with their parents. But from a purely legal standpoint, most laws, including laws that have gone all the way up to cases that have gone all the way up to the Supreme Court, support parenting as a basic right. And from the 14th Amendment, which I bet you didn't think we were going to talk about the 14th Amendment today, but that the 14th Amendment is about equal protection under the law. So it's the same amendment that brought us Brown versus Board of Education. It's the same amendment that brought us Roe v. Wade. And it is the amendment that is used when parents' rights are challenged in decisions they have made for their children. And most of that is because within the ethical landscape, we believe that parents are best suited to determine what is in a child's best interest. That they have raised that child from birth, that they understand their family unit, they understand the child's values, and that they are the ones that we should defer to assert what is in the child's best interest. But that is not to say that there is no role for government in intervening in parental decision-making. And the famous Supreme Court case of Prince v. Massachusetts in 1944 brought out this concept of parens patriae, which means protector of the nation or parent of the nation. And it essentially talks about the rights and role of government to intervene in that basic parenting right if what the parents decide means that the child will suffer undue harm. And so one of the most important statements from that decision, Prince v. Massachusetts, is that parents have a right to, parents are free to become martyrs themselves, but it does not follow that they can make martyrs of their children. And this case was related to a guardian of a 9-year-old, and the 9-year-old was asked to be on a street. They were Jehovah's Witnesses, and she was to be on a street corner distributing literature about Jehovah's Witness and receiving donations. And she was 9, and the state intervened and said, the parents have a right to stand on the corner and distribute literature and talk about Jehovah's Witness, but it's not appropriate for a 9-year-old. There are some exceptions to a parent's inalienable right to make decisions for their children. And the mature minor doctrine gives people under the age of legal majority the right to make decisions without consent of their parents if they can demonstrate to the court that they have the knowledge, maturity, judgment to make that decision. And so there have been a number of cases, namely of refusal of chemotherapy in patients under the age of 18 for a variety of reasons, for cancers that have a very high likelihood of survival, and the patients have refused them, some for religious reasons, others because they didn't believe that chemo was the way to treat cancer. And all of those cases really came down to whether or not one could utilize the mature minor doctrine to say this child is making a decision in their own best interest. And common law kind of follows the rule of 7s. So we say that up to age 7, children have 0 capacity. I have a 7-year-old, and I assure you he has no capacity. from age 7 to 14, children have the rebuttable presumption of no capacity. So we assume that they are not capable of making decisions, but there may be exceptions to that rule based on life experience, maturity, intellect, and courts have taken up cases for children between the ages of 7 and 14 and determined that they do have capacity to make decisions. So from age 14 to 21, then they are given the rebuttable presumption of capacity. We assume that they are capable of making decisions, and it has to be proven otherwise. So we all are aware of the law. We all are aware of deferring to parental preferences, but I'm pretty sure looking around this room, everybody has dealt with a case where there was a difference in preferences between the parent and the child, and there was some conflict about whose preferences you would go with. And so I just want to bring up the factors that probably influence providers feeling that the law is not the only thing we have to pay attention to. I think two other things that really influence whether or not we consider age 18 the magical cutoff is ascending age as well as prognosis. I think prognosis plays a big role in whether or not we allow patients to make certain decisions. So this was a study of hypothetical scenarios given to over 300 oncologists and pediatricians, asking them under what circumstances would they treat a patient over their refusal. So the teenager says to you, I will not get chemotherapy, and you would choose to treat them against their wishes. And I just want to, it's a busy slide, but what I want to show you is that if the parent wants the treatment and the child does not, almost all doctors would treat the 11-year-old over their refusal. But when you get to a 16-year-old, then there becomes a subset of providers that say, 16, that's kind of close to 18. And, you know, I think that maybe we need to think about respecting their autonomous decision making. And so there's a quarter of providers that said, I would not treat this patient if they refused it. And this is for a case of standard risk ALL with an 80% chance of survival. So now let's make it a little more interesting. Let's talk about disseminated metastatic Ewing sarcoma with a 15% chance of survival with treatment. Now all of a sudden, you have a 16-year-old who doesn't want treatment, close to the age of majority, right, with a pretty poor prognosis. And so that 16-year-old with a poor prognosis is refusing treatment over the preferences of their parent, and only 35% of providers would treat that child against their wishes. So I think we have to understand that the law is there to direct us and guide us, but the way we make decisions may sometimes be influenced by factors other than that, by how close the child is to achieving the age of majority, how invasive and the degree of morbidity associated with the treatment. And so we have to kind of think about the fact that there's a law as a guide. So as I said, I think it's really important to share the kind of emerging literature on the importance of hope in life-limiting illness, because, sorry. If there's anyone in this room who has not been in a care conference and given parents really bad news and then had the parents walk out of the room and say, I'm hoping for a cure. And then our knee-jerk reaction as providers is to say, they just don't get it. But I'm here to argue that they can get it and hope for a cure at the exact same time. So we know a lot from the cancer literature about what makes patients hopeful. And I'm just highlighting a couple because I think the things that help and help increase hopefulness in patients can all be facilitated by advanced care planning. So if you ask patients what makes them hopeful, it's that they've developed practical, attainable goals. It's not always, I just hope for a cure. It's, I hope for being able to still go golfing this summer, Sam. And that they want to feel valued and affirmed as a person, not just as a patient. And that when they feel abandoned or isolated and that decisions are being made for them, not with them, they lose hope. So this study done in Boston followed 32 families. They audio taped their care conferences, and then they interviewed the parents when they walked out of the care conference. These were all patients with relapsed or refractory cancer in which the medical team felt that there was essentially no chance of cure. So that was the inclusion criteria for the study. So they taped the family meetings, and this is the slide that tells me we can do better. So 100% of these patients had incurable cancer, and 44% of those patients were told that in a care conference. So that's not ideal, okay? But interestingly, what percentage of parents do you think recognized that their cancer was incurable or terminal, even though only 44% were told? So 88% knew the cancer was terminal or incurable and continued to hope for a cure. So we can just say it. It's not going to make them less hopeful, and they know it already. And one of the more interesting things, I think, is that almost all of them recognized that they were maintaining hope in the face of the likelihood that their child was going to die. So there is a disconnect between what we believe we're doing to a patient's sense of hope and what we're actually doing. And I think it's critical to understand that the idea of taking away hope is our own construct out of our own discomfort with talking about difficult things. Can look at the same issue in adult patients. So they did a really fascinating study of adult patients with cancer who were at the point of making a decision to proceed with chemotherapy or not. And they showed them these decision aids that told them how long they expected them to live with chemo and how long they expected them to live if they didn't take chemo. And so for this example, doing chemo gave them an extra 2.9 months of life. And they asked them how hopeful they were feeling before they reviewed this decision aid and had this conversation with their provider, and whether or not they were feeling hopeful afterward, in an effort to understand whether poor prognosis confers hopelessness. And the reality is that had zero impact on the amount of hope they had when they left this session with their provider. So if I can leave you with one message today, parents can understand terrible news, remain hopeful for a cure, and understand that those two things are inconsistent. And all of that really does still make sense. So do patients and parents want to talk about potential end-of-life decisions they have to make? Do they want to talk about what their preferences would be? Well, I think the answer is yes, and there are currently only 3 formal pediatric advanced care planning programs in the country. So the data is limited, but those 3 programs have all demonstrated that patients and their families certainly find it helpful and useful. And this was a study of ages 14 to 21 outpatients with cancer, and this was in kind of the preliminary phase of developing the intervention in the tool. And I'm going to talk a little bit about my research at the end, which is adapted from this advanced care planning intervention that I'll talk about. But they talked to both adolescent and young adults and their surrogate decision makers, which most of the time is their parent. And 95% of them said that the process was helpful, and none of them, 0, said that it was stressful. The most helpful piece of the conversation or the intervention was the idea of what they wanted their loved ones to know, that they wanted to share information about things that were important to them if their family had to make decisions for them. And after the take-home message of hope, this is the second take-home message, and a really important learning point for me as an intensivist is that adolescents uniformly do not care, nor are they interested in talking about specific medical treatments and making choices about specific medical treatments. Do you want a ventilator? Would you want dialysis? That's not their purpose in having these conversations, and it causes the most stress to them. And our study is showing that same thing to be true. So it sort of turns the concept of advanced care planning and completing an advance directive on its head, because most people, you know, when you're admitting 6 patients and you have to make sure they have an advance directive, it's, you know, check this box if you want CPR. For adolescents, that's stressful and not helpful to them, and we need to find a different approach to how to talk to them about end-of-life decisions. This is a study in adolescents with HIV who underwent the same intervention. Looking on the left is in their surrogates, and on the right is in the patients. They had a control group that did not go through the intervention, and these are just satisfaction scores. Sorry, so the right side are the intervention and the left side, the darker gray, is the control. And the bottom line here is that satisfaction among intervention participants was much higher than that among controls. This was a study looking at parents of children with chronic illness. You can see on the left, some of these children were clearly medically dependent with feeding tubes and trachs, and some of them went to school, some of them could walk. So these are children that are pretty medically involved. And they asked parents about, first of all, whether or not they had ever heard of an advanced care plan or talked at all about an advance directive for their child. And only 4% of them said that a provider had ever discussed goals of care with them. But 50% of them were interested in the idea of developing a care plan for their child. And I think we need to pay attention to both what they perceived as the advantages and what they perceived as the disadvantages of that, and that they really felt like they wanted to have control over things that happened to their child. And I think we can all attest to the fact that sometimes when patients start down the road of medical technology, they just continue on the road, and there's rarely times where a discussion takes place in the middle that maybe now is the time to talk about limitations of treatment. And so among the disadvantages, this is a uniform concern of both adults and adolescents in the idea of completing an advanced directive is that, how do I know now what I'm going to want 6 months from now or a year from now? And the lack of knowledge that they can always change their mind and readapt that document. And so I think it's really important when you're talking to patients about potential decisions they might have to make that this is a conversation in evolution, and as things change, we will revisit all of these questions. And then we know that they want to do it. The question is, when should we do it? When is the best time to talk to adolescents about potentially bad outcomes from cancer or bone marrow transplant? The gist of this slide is that it depends. So I think it points further to the fact that we really need to be engaging and normalizing this conversation as part of our treatment plan and part of our care, and ask them if they'd like to talk about it, when would they want to talk about it. It's quite variable based on the individual patient. But only 25% of them said they would never want to talk about it, so I think that's a good sign. It's just a question of when is the best time. So I am going to present my data in a second, and we do some taped interviews, and I know it's very challenging in a talk like this to put quotes up on a board and have you read them, but I think they're relatively profound, and I can't use the audio because we didn't add that to our consent form that it could be used in presentations, because it is pretty powerful to hear them speak it. But I just want to present to you a couple of the things we've heard from our study patients that have really supported the concept that patients really want to participate in this and that they find it helpful. Okay, so last but not least, I'll spend a little bit of time kind of talking about how we know when an adolescent has the developmental capacity to understand the impact of these large decisions they might have to make. And I just have to look at the last sentence. For those of you in the back who can't see it, it's one of these "do you like me" notes, right, with the yes or no. And then on the bottom, he says that I don't know myself yet. P.S. You don't know yourself until you're 18. So when we talk about capacity, we have to fully acknowledge that for all people, not just adolescents, it occurs on a spectrum. We could probably all recount a 45-year-old that we know that makes terrible decisions and a 15-year-old that we know that makes really good, logical, well-thought-out decisions. And so the idea that a one-size-fits-all approach to decision-making is a fallacy, and there is nothing magical that happens on your 18th birthday. There had to be an age at which the government decided you were old enough to fight in a war, and that turned out to be 18, and somehow that just magically became the age at which you become an adult. But we know that the limbic system of a child develops more rapidly than the prefrontal cortex does. So the prefrontal cortex, responsible for problem solving, rational decision making, thinking about risks and benefits, probably doesn't mature until people are in their mid-20s. But the limbic system, the "no way, I don't want to do that," the emotional response, the affective piece of it, starts to develop in early adolescence. And so that's why teenagers make more emotional decisions than intellectual decisions for the most part. And the biggest question when we're talking about these high stakes decisions is, do they understand the short-term and long-term consequences of their decision? Teenagers are very short-term driven, and understanding what the long-term consequences of that decision means is always something that we have to question. There's a really fascinating concept in psychology of hot and cold decision making. So when we are in a hot state, we are driven by our emotions. So we tend to, when we make decisions in a hot state, we tend to make them very emotionally. Whereas when we're in a cold state, we are using the part of our brain that conducts rational thought. And so in my mind, this is the perfect example of why advanced care planning should take place long before a patient is sick, is because we want people to make decisions when they're in a cold state, when they're under less stress. Making decisions in a crisis rarely results in good decision making. And there are some adult tools to determine decision-making capacity that have been adapted for patients under the age of 18, and they show very good validity when compared to kind of the standard way that we've been assessing children and adolescents for decision-making capacity. So those are available. So this study looked at cancer patients aged 10 to 18 who are making a decision with their families to either enter a phase 1 study or make themselves DNR. The family decided to make them DNR, and to pursue no further therapy. And when they asked them questions to determine whether or not the child had the capacity to make that decision independent of their parents, they found that 90% of them could recognize all the treatment options, understood the consequences of each of the treatment options, and understood that what they ended up ultimately choosing would result in their own death. So, and these are kids as young as the age of 10. I think what's interesting about this is that the major factors that led to patients choosing to seek further treatment was how that decision affected their families, and that they knew that cure was unlikely, but their parents still believed in it, and so they wanted to please their parent. And we've actually found pretty similar data in our study as well, that fascinatingly, the child feels the need to protect the parent. And also that seeing others die around them dramatically affected the choices they made. If they were friends with someone on the ward who had bad side effects and died an unpleasant death, they were more likely to not want aggressive care. And so I think those are important things to know. So I'm going to spend the next couple minutes talking about our study. Angie Smith and I are funded by Children's Cancer Research Fund and the American Cancer Society to adapt what is the FACE intervention, so it's Family and Adolescent Advanced Care Planning Intervention. It was previously validated in outpatients with cancer and HIV, and we adapted it in the inpatient setting for patients with bone marrow transplant. So all patients age 14 to 25 with cancer who are undergoing bone marrow transplant are potential patients for our study. When they agree to be in the study, they participate in 3 sessions that are facilitated by our social workers, and I need to give a shout out to Janet, Gabe, and Marie for doing an amazing job with these patients. And I think one of the reasons we've been very successful and had 100% enrollment in our study is that we're utilizing interventionists who are embedded in the bone marrow transplant program, understand the process, understand the needs of these families, and so it just normalizes this as part of their process. The first session is that they go through a questionnaire that's facilitated by the social worker, just kind of breaking the ice to talk about the concepts of death and dying and what they know and what their family talks about. The meat of this intervention is session 2, where they have about a 90-minute interview going through, I'll talk about further, but their hopes, their goals, what a good day means to them, how their illness has affected their life, what they want people to know if they can't make decisions for themselves. And then the conclusion of this, the third session, is where they complete something called a statement of treatment preferences. So for the patients over the age of 18, this can be a legally binding document, and in addition, they may complete an Honoring Choices Minnesota advance directive, but for the patients under 18, it's a statement of treatment preferences. It is not a legally binding document, but we have them complete it. And then we have added exit interviews to address some of the more qualitative components of this study, because it felt like it was just much more than a feasibility and acceptability pilot, which is sort of how we designed it. But we felt like there was so much rich data to be obtained that we had to kind of add some qualitative pieces. So we're looking at the effect of the intervention on improving congruence between the adolescent and the surrogate. And I might have forgotten to say that this entire intervention is conducted with the patient and their parent together. So these conversations are done as a dyad. Looking at the impact of the intervention on decisional conflict, and then we are doing exit interviews to discuss kind of the experience of the intervention in their process, the experience of the bone marrow transplant, exploring this idea of hope and how they maintain such tremendous hope in the face of this illness. And we have yet to do, we're only 6 months into the study, but we are planning to do focus groups with providers to look at whether or not there is an impact on moral distress of providers providing aggressive life-sustaining treatment for patients if they know that they've gone through this intervention and made thoughtful choices about what they want. So that is not a typo. The N is 4. We just started. But everyone we've approached has enrolled and had no adverse events from this. And we defined an adverse event as, on a satisfaction survey, them agreeing that it was harmful but not helpful, and we've had nobody say that it was harmful. So 100% have strongly agreed that it was worthwhile and helpful. Nobody has said it was harmful, and 75% of them felt like it was something they needed to do but just hadn't. I think the session one where we go through a questionnaire, this, to me, we in fact had one patient on his third relapse of cancer and second bone marrow transplant, and they said that they have never talked about death or dying in their family. So we are understanding why this is so important when we ask them what prior discussions have taken place in your home. The answer is usually none. And as I talked about before, when the data suggests that adults really aren't interested in talking about the details, the nitty-gritty specifics about end-of-life decisions, our study is showing that, in fact, to be true as well. The least important to them on this survey was being off machines that extend life. So they're not really considering the detail focus of the decisions they're making. It really is kind of what they want from a global perspective. And so session two is where we sit down and spend a good amount of time going through a scripted interview, and this is designed through the Respecting Choices program at Gunderson Health Systems. They have first steps, which is for patients who are not sick at all, and it helps them just define a proxy as well as start to think about some of their end-of-life care preferences. Next steps is for patients that have a specific disease and need to go through some advanced care planning. And then final steps is for patients kind of in the terminal phase of death. And so we're utilizing next steps and it's been adapted for adolescents. So that's we were trained and certified in being in the Respecting Choices program, and you go through, and we pretty much try to stick to the script, and then you go off when things get interesting, but it helps us, kind of keep it reliable. And we really explore a lot of things that have nothing to do with medical care. What are they hoping for in their treatment? And we spend a lot of time talking about that. And the number one answer is always, I'm hoping for cure. And then we ask them again, what are they hoping for? And again, and again. And we get down to, I'm hoping I can be out by summer. I'm hoping I don't lose my hair for too long. And then the kind of the punchline question that we always ask is, and if cure is not possible, what else are you hoping for? And that gets them to think about what is important to them if their number one goal of cure is not attainable. Here's some really interesting things. We talk to them a lot about what they're afraid of and what fears they have about going through treatment and their disease in general. So this statement of treatment preferences is 4 scenarios, and it is unlike most advanced directive documents you've probably ever seen, because the scenarios are set up to be very values-based. And so this first scenario is that you have a complication, treatment for that complication gives you a 5% chance of survival. And would you continue all treatment or stop all treatment? So we lump treatment as a concept, not I want this, but not this, but not that. No Chinese food menu. We only talk about it as an all treatment concept. So before the intervention, we have them fill out the statement of treatment preferences. Then we facilitate the discussion about it in the intervention, and then we have them complete one afterward. So all the patients, and I'm only going to speak about the patients now, the surrogates do them too, but I didn't have enough time to really go through the surrogate data. But all the patients wanted to continue all treatment with a 5% chance. We went through the intervention. They can talk about why they made that choice, and none of them changed their mind. So they all felt that 5% is not 0, and that they are going to take whatever chance they can. I will be interested as this intervention starts going to other patient populations, whether there is something unique among BMT patients, that they are fighters more than the average bear, and that 5% sounds good enough to them. It surprised me, but that's where we are, and they all are pretty consistent across the board that 5 is not 0. Can't argue with them. The second situation is that your cancer has spread, you're going to live only 2 to 3 more months, and the side effects of your treatment are serious. So this is sort of the quality, quantity life discussion. So before we went through the intervention, 1 patient definitely wanted to stop, and 3 of them were really unsure about how they felt about it. And this, to me, is the power of having this conversation, because by the time we went through the intervention and they completed it again, and they talked about what was important to them, and they talked about it with their parents, 1 patient decided that they wanted to continue treatment, that 2 to 3 months was good for them. But most of them decided that they wanted to stop treatment. So there was a shift after kind of embarking on this values conversation. So this one is about more physical morbidity. So you have a complication and you're going to live, but you probably will never walk or talk, and that you need 24-hour nursing care. So before the intervention, half of them said, that's all right. Walking, talking, I'll still be alive, and half of them were really unsure. And after the intervention, the same ones who wanted to continue decided to continue, and then 1 who was unsure decided he wanted to stop. And interestingly, this child was a really successful athlete, and the idea that he could never walk again was really got him to the point that he felt like his reason for living would not exist if he was unable to walk. And then this is the one that always gives the most pause when you wait to hear how the patients are going to answer. But this is, you have a complication, you will never know who you are, you won't know who you're with, and you need 24-hour nursing care. So essentially the devastated neurologic outcome. So before the intervention, all over the board, a lot of unsures, and led to some really rich conversations between the parents and their child about what this would mean for them. Interestingly, the greatest concern for the patients who wanted to continue treatment was the fear that they would be a burden on their parents. And so facilitating that conversation between the parent and the child, when the parent said to them, I would never think of you as a burden, it was very meaningful. It opened up a lot of, I think the child was very worried about that, and the parent was able to say to them that we would never think of you that way. But after the intervention, the 2 unsures all decided that ultimately they wanted to stop treatment. So I'm going to move along. I'm ending with this quote. Just said, can I get an amen? So in conclusion, I think there's sufficient data to suggest that advanced care planning facilitates a conversation that probably wouldn't happen otherwise. It is the most respectful of patient autonomy, even if the patient is not an 18-year-old, that there's no relationship between embarking on advanced care planning and patients losing hope, that we need to recognize that some adolescents do have capacity to make decisions like this. It's important for us to focus on the big picture and not specifics. When we want to know whether or not they want to be intubated, that's probably not the way we should be having that conversation, that we need to focus on what it might mean for them to be intubated. That patients want to participate. So far, we have demonstrated feasibility of this intervention. I meant to write parent there, but to recognize that the impact that adolescents feel like the decisions they make have on their parent, sorry, not patient, parent, is really one of their driving factors. And so we should just address that elephant in the room and address it with both the parent and the child to help, encourage the child to make a decision based on what's right for them, not their concern for how it's going to impact their family. And I will just put in a plug, because I know people won't admit it, but I'm betting not very many people out there have advance directives and have not had conversations with their loved ones. So here is the website to complete your Minnesota Honoring Choices form. And I would just encourage everyone to do it, healthy or not. It's something that's really important. So thanks for having me, and love to have some discussion.
Thank you, Dr. Nato. This has been very helpful. What I wanted to ask was about if there's any information out there about, I can imagine these young people have multiple providers, and so I'm curious about who, if parents or families have preferences on who should entertain or open this discussion. And then the second part of the question is, for those who have multiple providers, is there any communication between providers about what you may learn if you open the discussion with family and people?
Right. Well, that's a great question. So as I said, most of the data is in the cancer literature and suggests that most patients want their oncologist to be the one initiating the conversation. We do ask that question in our survey about who would they want to bring up these discussions with them, and they can check more than one thing, but I will tell you that all four of them, in addition to providers or family, all put social worker. And so I think that does suggest to us that we probably need to have this as a multidisciplinary approach. There is one program, it's called the Footprints Model. It's in St. Louis, and they have not only an advanced care planning component to it, but they have a multidisciplinary institutional care plan for each patient. So the complex neurodegenerative disorder who may be trach vented and has, Duchenne's, and they're trach vented and they have cardiomyopathy, so they have multiple subspecialists. That program coordinates all of them within the advanced care planning process. So that's sort of a model we could all strive for. And my goal is to, in the hopefully near future, bring this outside of the cancer population and start looking at some other populations of adolescents who might really benefit from this, notably cystic fibrosis, as I said, muscular dystrophies. So I think, and solid organ transplant patients that are adolescents, I think you could see this being really useful in a lot of patients outside of cancer, so.
Thank you as well. I thought this was really brought up a lot of questions for me, and you're getting the generalist adolescent health section over here. So I'll go with some adolescent questions. And I'd appreciate your input. So elephants don't sneak into rooms, right? So it's there, and my belief is that there's probably something we can do before we need to be talking about end-of-life care,
right,
that might make this conversation easier. I'm even seeing this in the context of pediatric care, and why do adults not want to talk about it? Because we didn't have these conversations about values and decision-making early in life and how that relates to our care. So if you could imagine what it would look like to have a continuum of discussions, starting with well-child check, or maybe even for someone who's getting a diagnosis of Crohn's disease.
Right.
What should this look like at the beginning?
Right. Well, it's a great question. And there was a study that I did not put up here, but the Maryland State Legislature passed, I think in 2013, a law that asked all pediatric hospitals to have patients complete a MOLST form, so medical orders for life-sustaining treatment, whether they had chronic illness or they were getting admitted for bronchiolitis. And there was this huge concern that this was going to be tremendously upsetting to families of really healthy kids who are in the hospital for a day or two to be talking about things like this. And in fact, that wasn't true. It was very well received. And I think that this all comes down to normalizing conversations about the realities of life, recognizing that there will be a probably significant subset who tell you, stop talking, I want nothing to say about this, and that's okay, but that I think that most people appreciate the opportunity to just even think about things like this. And so, yeah, do I think there's a role for any child who's admitted to the hospital with potentially life-limiting illness? Yes. And I think we use the "they don't want to talk about it" excuse instead of "we don't want to talk about it." Because it's uncomfortable when patients say to you, stop talking about that. And so I think we have a ways to go. I think we're, the culture of comfort with death and dying, I think, is getting better. I think as boomers age, and so their children are starting to grapple with these conversations with their parents, we may see a shift where it's become, the death panel, Sarah Palin issue really put a serious damper on people's ability to bring up these issues without having patients feel threatened. And hopefully that memory is fading. But I think we got a ways to go. Yeah.
So this basic construct was done at Gunderson. And I'm just wondering if you guys are planning to look at cultural differences, because I think that, the words that people use in different cultures and their impact on health beliefs, or actually flip it, how their health beliefs impact, the words that are being used and things like that. And, I'm not just thinking about African Americans, which again have some very distinct health beliefs, but we're dealing with very devout Muslim families. The whole spectrum, spiritual, Hmong.
Yep.
So I'm just wondering, sort of long term or short term, are you looking at validating this for different cultures, or how are you maybe testing that?
So our next phase is going to be actually translating this intervention into Spanish. We have to start with little pieces that we can bite off one at a time because it's such a huge undertaking. So the next phase is going to be, right now we're only enrolling English-speaking patients. So the next phase is going to be translating the intervention and doing it in Spanish, and then adding on some components of kind of cultural competency to understanding how we do that, but it's going to involve a lot of focus groups and a lot of community engagement before we do it. So that's step one. And 10 years from now, when I give this talk again, and we've done it in 8 languages, I'll tell you. But yeah, we're going to just do it piece by piece. Yes. Right. Yep. And initially, this intervention actually started in HIV patients in Washington, D.C., and 100% of them were African American, and they spent a lot of time, as I said, doing community engagement programs, focusing on wording, specific conceptual things. There's issues about children who are orphaned. Children with HIV have often lost both parents. And then who is their guardian that can speak for them that way? So yes, we're trying to validate it in general as a really effective program, and then we can expand it.
It is 8:30.
Thanks, everybody.